Okay. Hi, everyone. My name is Yuding Wang. I'm one of the chief urology residents here at McMaster University. It's my pleasure to welcome everyone and to introduce Dr. Luis Braga, who will be giving us a talk about childhood urinary tract infections and pyelonephritis. Next slide.
Thank you, Ding. It's a great pleasure to be doing this live talks for all of you. And I think a big thank you to Hillary Kopp that I think had the great idea to put this together. And I've seen like many of our colleagues across the centers in the US. So let's get it started. The topic that I chose was childhood urinary tract infection and pyelonephritis. So just to show McMaster, we come from Hamilton. So it's right in the southwest part of Ontario. Close to Niagara Falls, Buffalo, Rochester, and then 65 kilometers from Toronto, where the Hospital for Sick Children is. So what I would like to talk today mainly will be those 5 topics: the burden of UTIs, why should we care about managing children with urinary tract infection, the definition and diagnosis, risk factors. Again, this is as any lecture or a topic of UTI, this is very vast, but we're going to try to focus on the most important ones that will be relevant to the pediatric urologist, such as BBD, VUR, and circumcision, and the treatment. So urinary tract infection is a burden. And why is that? As you can see here, almost 3% of American children are affected by UTI annually. And this will account for almost 1 million medical visits a year. So all medical students, all residents, all fellows and staff, from the day they start medical school until the day they retire, they will be seeing UTIs at least once a week because it's very prevalent. So in terms of costs, generated by treatment of pyelonephritis, this can come up to almost 180 million a year. So it's a big burden, as mentioned by Fried in 2005. So in terms of why we should care about urinary tract infections, we know that it is a common cause of bacterial infection in children. So in terms of the workup for fever, 20% of the visits that are due to this reason will be caused by urinary tract infections. And then according to this data, 70% of all the febrile episodes are responsible, so urinary tract infection will be responsible for 7% of these episodes of fever that are investigated by family doctors or pediatricians. An important thing is that a UTI has an age and gender effect. As you can see from the table below, we see that in children under 1 year of age, the prevalence of males is higher than females. And after that, this will flip and females will be more prevalent, where UTIs will be more prevalent in girls than boys. So in terms of urinary tract infection and this prevalence, I would like to show this graph that was published in 2001. And what shows here that actually in the first 2 to 3 months, the prevalence is a little bit higher or higher in boys than girls. And after that, as you can see here, so the square will be the female, the diamond will be all UTIs and the percentage, and then the triangle for males. And then you see that there is almost like this number of those those 3 figures will converge around 3 months of age, or especially after 2 to 3 months. And after that, we'll have what has been shown in the previous slide, that the females will have a higher prevalence of UTI and the male ones will decrease. And we'll see why that happens. So we should care about urinary tract infection because of the morbidity that is associated with that this condition, and also about long-term problems. One of them could be renal scarring, and then this will lead to renal insufficiency, hypertension, etc. So it is known that 20 to 35% of children that are investigated after first urinary tract infection, especially the febrile UTI, will have vesicoureteral reflux. This is a picture that was that I borrowed from my good friend Armando Lorenzo, and showing here this indent, which is the classic sign of a polar defect, which is classic of renal scarring, probably due to recurrent urinary tract infections. So 10 to 20% of children or 10 to 20% will have renal scarring at presentation. So these children, when they have the first UTI, the scarring is there. I would like to make a little caveat here that because of the nomenclature or the literature doesn't differentiate well what is renal scarring from the renal dysplasia, you may see that sometimes authors or papers are using this term indistinctively. But as you know, the renal dysplasia is something that happens, it's congenital. It's like an embryological anomaly due to the metanephric blastema. And then the urethral bud will come from that abnormal metanephric blastema and created reflux. So usually, you know that those patients have congenital dysplasia when the kidney is globally reduced, that has poor function and associated with high-grade VUR. One thing that needs to be said is that when you use ultrasound or even renal scan, it is impossible to differentiate real acquired scar from episodes of pyelonephritis from a congenital dysplasia. So one thing that is interesting here is that we know that the more UTIs, the higher the chance of getting renal scarring. So as you see here, after you have 3 or 4 urinary tract infections, then the risk of renal scarring is much greater. And then the percentage is up to greater than 6 to 7%. So when we look at the RIVER trial in 2014, look at this. The new scars were more prevalent after UTI, 22% versus 3% of patients who had just like non-febrile urinary tract infections. And one thing that was important that the RIVER trial showed that the risk of or the rate of renal damage was much lower in boys. Therefore, in terms of risk groups that we're going to talk about later, girls, the antibiotic prophylaxis was recommended more for girls with higher grade reflux than boys. So again, one important thing about urinary tract infections is that up to 80% of girls will have a second infection, and 10 to 20% of febrile UTIs can result in renal scar. So if you can prevent that, or at least not allow them to develop the third or the fourth, it's very important, and I think it's our job to do that. So in terms of diagnosis, as we know, it varies by age, and the presentation in neonates is usually like a systemic event, and sometimes patients will present with sepsis, which is, again, a severe condition that needs to be treated immediately. In infants, they can present with GI symptoms, failure to thrive, and fever. So these are inspecific symptoms that you have to use your experience and rule out other conditions in order to be able to diagnose a UTI. And in older kids, school age and adolescents, then you have the classic symptoms of lower urinary tract symptoms, LUTs. So one thing that is important, and I find that I decided to highlight this in this presentation, especially for the residents and fellows, is that with technology, we have lost emphasis in clinical history and physical examination. So it's very important to pay attention at physical exam, especially in pediatric urology, and we're going to show why. So in terms of UTI, and then trying to find signs that would be associated with urinary or more likelihood of having a urinary tract infection would be the presence of masses, tenderness of the abdomen. In the perineum, always look for discharge, bulging masses, labial adhesions, and then make sure that this patient has a normal anatomy, which means that if it is a female, a urethra separated from the vagina, 2 orifices, as opposed to a urogenital sinus or even a cloaca. In terms of examining the back, check for skin tags, masses, dimples, and vascular malformations. So what are those important physical findings? So one of them is this one, a classic urethral seal. You can see here in a duplicated collecting system, we do the classic ultrasound with this cystic lesion. And then in the perineum, you see this bulging just above the urethra, bluish. And then those patients actually not treated will develop a UTI or sepsis. So most of them in these conditions, they go for puncture or even incision at bedside. In terms of another duplication anomaly that we see associated with UTIs or ectopic ureters, you see sometimes a non-functional or poor functioning upper pole connected to this ectopic ureters in the vestibule. It's hard to find the insertion of the ectopic ureter, but sometimes you're lucky or there is pus coming from that area. Again, as I mentioned, in a classic case of neurogenic bladder, you can see the Christmas tree bladder shape with bilateral VUR, and those patients sometimes they just have like a spina bifida occulta, a small dimple, or some gait abnormalities. So suspicion is key. to be able to detect these intrinsic abnormalities. So again, very common in young females, labial adhesions. And this is a problem that the mothers usually are very concerned. And then sometimes in those cases that you have complete occlusion or fusion of the labia, then they can have vaginal voiding, reflux of urine into the perineum, and then recurrent urinary tract infections. And finally, a very common and prevalent issue, I think not so much in the US, but or a little bit because of the Latino population, but in Canada, 45% of the 65% of the population is not circumcised. So the tight foreskin and the pooling of urine on the foreskin is a common cause of bacterial or urinary tract infection. So, and finally, as Dr. Kopp showed yesterday, we see the issue of posterior urethral valves, the most common cause of luteal, but also an important cause of postnatal urinary tract infection. And these patients are always quickly put on antibiotic prophylaxis, and they have to have the catheter to drain the bladder and stabilize in terms of electrolytes. So how can we establish the diagnosis of UTI? So the important thing is about the collection method. You can have a suprapubic aspiration, catheter specimen, and midstream voided urine. So this is usually recommended for older patients where you can retract the foreskin in uncircumcised boys or separate well or spread the legs in older girls. The only advantage of having a bag specimen, which is commonly performed, is that if there is no growth, then it's useful. But otherwise, this is a huge source of contamination, but unfortunately, it's frequently done in outpatient clinics and everywhere, and even in the ER departments. So the first question is this one: which of the following defines a urinary tract infection? So I'll give you guys 20 seconds to answer, and then we're gonna comment each option and then continue the lecture. Great. Most people answer if suprapubic aspiration was performed, then recovered of any organism defines a UTI. That's correct. So half of those got it right, and we're going to explain why. So urine is considered sterile. What is important is that according to the American Academy of Pediatrics, in children who are not toilet trained, and especially under 2 years of age, you should have either a collection method through a catheter or through suprapubic aspiration. So in terms of the Europeans and Australia, so NICE is from the United Kingdom, Italy, and then the Australian ones, they rely more on clean catch specimens. And why is that? As you see here, when you compare clean catch for culture versus suprapubic aspiration, you have a sensitivity of 75 to 100 and a specificity of 60 to 100. When you compare the catheter specimen versus suprapubic, which would be considered gold standard, you have a much higher sensitivity of 95% and specificity of 99%. So catheter specimens is better as shown here, but why would many physicians rely on this? And the answer is right there. We know that for us to be able to diagnose a UTI, the gold standard would be the urine culture. But it's very important, the urine analysis, when you use the dipstick and microscopy, that this will increase the likelihood of you establish a correct diagnosis for UTI. So the problem with the culture that we don't wait is because it takes 18 hours to show any type of growth, and then sometimes 2 to 3 days to have the final result, and with the antibiotics sensitivity. So what we try to do is this. Like the American Academy of Pediatrics recommended, the absence of pyuria in children with true UTI is rare. So if you observe that you have more than 5 white blood cells per field, this is likely that this child will have a urinary tract infections, provided the symptoms are there. In terms of the dipsticks, the important lesson here is this. You have to combine the leukocyte esterase and the nitrates. And when you do that, you have a high positive predicted value. So when they are both negatives the same way, you're going to have a very high negative predicted value. So therefore, if it is negative, it's very likely that it's not a UTI. If it's positive, it's very likely to be a UTI. One thing that it's important, I think you used to do more in the past, that the microscopy looking at the microscope is not oftenly done, but we need to be always have in mind that uncircumcised boys, you have to be careful for that. And then if the patient is not circumcised, you have to retract the foreskin. So what we know and what we've seen from the previous slide, that most mark that the urine is considered sterile. So if you have a suprapubic aspiration, that's why any type of organism will make your diagnosis of urinary tract infection. According to the AAP, this was a change in criteria for the past 10 years. Greater than 50,000 colon per ml, this established the diagnosis, again, from a catheter specimen. If you have a clean catch, then you need more than 100,000. And this is from the early studies from Hoberman in 1994. Again, I'm not, I don't want to reemphasize, but it's always very important to take into account the symptoms, because sometimes you get family doctors or pediatricians that will order tests with a complete asymptomatic children, and this will create a diagnostic dilemma and a problem. So one thing that has been described more recently and by the Australians and the Americans is this, is trying to, again, not what is recommended currently by the American Academy of Pediatrics, but trying to obtain a clean catch even in non-toilet trained children. So this is what the Australian, when they published this in 2016, called the Quick Wee trial. You get a wet gauze, rub in the suprapubic region of babies, and they will void spontaneously. And at that point, you can catch this, and usually it takes less than 5 minutes to have the spontaneous voiding. So the Americans look at this and trying to do a study comparing, this was published in Pediatrics by LaBruce and al. And then this is, I decided to borrow those pictures to show you how the ER doctors and the nurses are doing to obtain clean catch urine in babies who are not toilet trained. So the problems with this method is the one, that there was more contamination, 16% versus 6% when you have like a catheterized specimen. The success of them achieving micturition spontaneously was only 50% of the time, and this is mainly effective in babies under 3 months of age. So I decided to highlight this because many emergency departments are already converting to this technique, including ours here, and we have had some issues that patients have been submitted to unnecessary tests because this was a false positive. So what is important in this, to summarize then, as shown here by this table, is that when you have a transurethral catheterization, so the probability of the infection is at least 95%. So important to see here, look at that. In a girl with a clean voided specimen, if you have only one attempt of voiding, this is a probability of infection is 80%. So that's why in the past, some studies and some doctors would recommend at least 2 or 3 in order to try to increase the probability of infection by getting several specimens that it could increase this chance of being more accurate. So what is the diagnostic accuracy? And then based on the symptoms and the signs of urinary tract infection. So as I mentioned, we have to take, especially young babies, a high index of suspicion. You have to look at how ill is that patient and how you're going to collect the urine. So this is mainly valid for infants between 0 and 24 months that present to the ER department, and as Sheikh showed in 2007. So with the following risk factors, when the temperature is greater than 40 degrees, has been lasting for more than 24, 48 hours, there is no other source, suprapubic tenderness, and if the baby is uncircumcised, this is very, very likely that this will be a true urinary tract infection, and you just need to do your test and it will confirm that. So this is a picture. I apologize for this slide. I took a picture from my Campbell's. But if the child presents with temperature greater than 38 without a clear etiology, you divide in 2 ways, less than 30 days or 29 days and greater. And then this one has the full sepsis workup. When they're older, then you analyze again how the child is presenting. If they are toxic and very ill, then it's the same one as before. If they're not, then you have an option to do a CBC and see how the child is and reassess things in 24 hours. So the next question is, which of the following statements is false? So children, instead of reading, I'm just going to give you the 20 seconds and then we'll comment on the answers. So most people answered letter D, 3% to 5% of febrile UTIs of children. Oh, sorry, 3 to 5% of febrile children. So children with a fever have urinary tract infection. That's correct. So I'm sorry, I had a problem here. So according to my answer, and then again, this I think was the way the sentence was worded. And I think even when I read now before the answer, I got it wrong. So the main thing here is that not 3 to 5% of children have urinary tract infection. So what I want to focus here was mainly that after 1 year of age, UTIs are more prevalent in females. And this is going to persist until the end of life, like in the elderly, in the older females, in the teenagers, and young girls. The only time UTIs are more common in boys than girls will be in the first year, especially in the first 3 to 6 months of life. So sorry. So in terms of the host risk factors, again, obviously we know from textbooks that when we look at UTIs, you have the bacterial risk factors, but we're not going to look into this due to the time constraints, but I think I would like to focus more on the host risk factors for urinary tract infections. So again, just to highlight what we mentioned in our questions, the relationship between gender and age with urinary tract infection. 7% of girls and 2% of boys suffer a UTI by age 6. So that's why UTI is a very common and prevalent issue. So what I mentioned here, that was the caveat from that question. It's 5% of febrile children have urinary tract infection. And I think there was a mistake in that question there that I see now. In terms of UTIs, again, I mentioned they are more prevalent in boys than girls, younger than 1 year of age. And then the prevalence from this old paper, like 35, 40 years ago, almost 3% in boys versus 0.7% in girls. Again, after that age, according to AAP from 1999, girls have a 2.2-fold higher risk than boys. One important thing about UTIs is about race. It is much more common in Caucasian girls. And of course, we have to take into account the foreskin. So circumcision has been shown to reduce the rate of UTI in the first 6 months by 10-fold. So the role of foreskin or the role of circumcision in reducing urinary tract infection is the following. According to this paper from Singh and Greenwald in 2005, what they shown was that patients who had healthy young normal boys, the number needed to treat was 111, which means that you needed to perform 111 circumcisions to reduce 1 urinary tract infection. When patients had recurrent UTIs, that number dropped to 11. And then in patients with grade 4 and 5 vesicoureteral reflux, that number was 4. So therefore, the circumcision wouldn't be recommended for every single male infant, but those with some predisposing factors such as recurrent UTIs and then high-grade VOR, posterior urethral valves, or other abnormalities. So, of course, based on the huge randomized trials done in Africa, circumcision has been associated with a reduce in the rate of STIs, HIV, but mainly in high-risk population. So, having said that, in 2002, the AAP Task Force on Circumcision released the following statement. Male circumcision is a common procedure, especially in the United States of America, and they concluded that the health benefits of a newborn male circumcision would outweigh the risks. Therefore, in the conclusion, even though they could not recommend this to every single baby boy that was born, they said that this would justify access, and then that this had also to be covered, and that's why their recommendations. So the specific benefits identified include prevention of UTIs, penile cancer, and transmission of some STIs. So this has been shown in adult populations and in high-risk patients, especially in the African trials. So in regards to the other risk factors, what do we need to take and bear in mind about the fecal and the bacterial colonization? So girls have more predisposition to have UTIs, especially because the E. coli, the most common bacteria that cause UTI, comes from a fecal perineal urethral root. Therefore, if you have a short urethra with the vagina, the rectum closed, this will facilitate that penetration of the bacteria and then making the bacteria access to the bladder. So obviously anatomical abnormalities such as hydronephrosis, megaurethra, duplication anomalies, neurogenic bladder, BBD, and vesicoureteral reflux. So I wanted to put this slide because I think it really illustrates what is going on with patients with BBD, females, and all that group of conditions that have to be acting either in isolation or concurrently to cause and then trigger that urinary tract infection. So we can start with constipation. So the big dilated rectum sometimes is going to push on the bladder. This can be a source of, as we know, dysfunction of voiding. This may lead to bladder instability that, again, patients who have chronic UTIs or have neurogenic bladder, they already may have bladder instability. This leads to urinary incontinence, some dampness in the underwear. Also could lead to, if they have overweight or chubby legs, they have regurgitation of urine to the vagina. So this leads to improper wiping or hygiene, that it's not easy to be done because they are wet through the 6-7 hours they stay in school. And that dampness, this increases the perineal colonization. And then in terms of, to add on top of that, these kids are not drinking well. So the inadequate fluid intake would lead to a decreased urine output. Then this will have less frequent voiding, so we cannot flush that bacteria that it's in the air or stasis, with sometimes even with the constipation, high post-void residue, and you have more bacterial in the bladder and then incubation, and this will lead to multiplication and a UTI. So let's talk about one of the most important factors, I believe, for urinary tract infections, which is bowel bladder dysfunction. So this is a well-recognized factor, and then there is a classic association between BBD and UTIs. So we know that BBD predisposes children not only to urinary tract infection, but also to renal injury. And this has been well shown by Piet in 2001. So children who have vesicoureteral reflux and BBD, they have higher risk of developing recurrent febrile UTIs. So 45% versus 15% when they didn't have BBD. So it's 3 times higher and was well documented in the paper in 2010. So what can we do to improve that? As you guys know, the most important thing and most effective way to prevent BBD or treat BBD will be urotherapy. And this is actually comprised of 4 single measures. One is time voiding every 2 hours. Then the increase the water intake as we've shown, most kids in the school age, they don't do that. Management aggressively constipation, as most of these kids, especially the girls, are constipated, and adequate perineal hygiene. Our group was able to trying to look into this, and we put together a video that could actually educate parents and children in order to be able to achieve behavior modification and improve the BBD. So vesicoureteral reflux, that's one of the last risk factors that I would like to talk about, the population of high risk that is associated with UTI. As you all know, there is primary and secondary VUR, secondary to bladder abnormalities, neurogenic bladder, PUV, or any condition that creates an outlet obstruction. And the primary is mainly the congenital reflux due to a deficient submucosal tunnel. So what has been classic teaching for us is that VUR is found in 24 to 40% of children who have been investigated with VCUG after the first urinary tract infection. So, and basically you have 2 main ways of making the diagnosis of VUR. One is with a classic voiding cystourethrogram, with the classic advantage of having a good delineation of the anatomy, being able to study the urethra to rule out other problems. You can grade well reflux and then see associated anomalies with a diverticulum, trabeculation, etc. So usually it's recommended for follow-up when you use scintigraphy, the nuclear cystogram, because you're going to reduce the radiation exposure. But as you can see from these pictures, you don't have the same level of detail. So it's hard to be able to really distinguish grade 3, 4 and 5 VUR, but at least you'll be able to see if the patient has persist of this reflux if you're doing follow-ups, and then you want to decide if you want to keep or stop continuing antibiotic prophylaxis. So one other thing that I know that I'm doing as part of this series, you're going to have a talk on VUR, so I'm not going to go into details of this, but it's impossible to talk about urinary tract infection without talking about the vesicoureteral reflux. And as we know from the International Reflux Classification, before we used to grade reflux in low and high grade. So high grade would be reflux 4 and 5, and low grade 1 to 3. But now we have done a shift in terms of these bars coming from the blue line to the red one, because now we divide reflux in non-dilating versus dilating VUR. And why is that? Because we know that dilating VUR has a high likelihood of having associated with renal scarring and even recurrent urinary tract infection. So in terms of the next question, which of the following is not true regarding renal scars? Perfect. Most people also got it right. So if you guys remember that first picture I showed from the indentation, so usually pyelonephritis will occur at the poles, in the poles of the kidney, and associated with the compound papilla. So what happens with this? So we know that there is an increased incidence of UTI if you delay the treatment, and we're going to look at some statistics that if you delay more than a week, then the chance of having renal scarring can go up to 70%. As I mentioned before, you cannot differentiate from renal dysplasia from renal scarring. One is the problem of the ureteric bud insertion in the metanephric blastema, probably creating reflux because there is less tunnel into that bladder detrusor. And also, we know that when you have scar, you have loss of renal parenchyma. And that's the problem that this may lead in the future to even renal insufficiency or sometimes hypertension, depending on the effects on the kidney and the amount of scars. So I would like to dedicate a few slides to pyelonephritis. So what is pyelonephritis? The definition will be a urinary tract infection that is associated with high fever, clinical symptoms, nausea, vomiting, flank pain, and sometimes those patients are sick, they are lethargic, they present with, you know that you have to admit them to the hospital. So the problem with pyelonephritis and the diagnosis is that there is a high false positive rate when you rely only on symptoms to make this diagnosis. The gold standard for diagnosis would be the DMSA, and as shown by Rushton in 1992, up to 2/3 of patients with systemic symptoms, they will show inflammatory change on DMSA. The question is, when does the DMSA is going to be done, and then we'll be able to show either inflammation or real scarring. So what one sees when a patient presents with the pyelonephritis, if it's done acutely, you use the DMSA and you see the photopenic areas like shown here. And as I mentioned, they will occur at the pole of the kidneys. Like, it's a Pac-Man, like, there is a bite here. And then sometimes if you see more that shrunk kidney, this is more likely to be congenital dysplasia. But sometimes we've seen in patients who don't have access to medical treatment and come from far away distance, they have had multiple recurrent infections and then shrunk kidneys due to acquired pyelonephritis. So the diagnosis is based on the time after the acute episode, and the maximal sensitivity occurs 1 week after the acute pyelonephritis. So DMSA has been shown that if done 10 days after that acute episode, the results will be abnormal in almost 80% of the time. So my following question is this: which of the following statements is false regarding the role of VUR in the development of pediatric UTI? So this is a question that I see. I think it's interesting because we have the answers are all split over, and this is a question that I see often in exams. And sometimes, and I think when I was studying, I got this wrong, because we have this, as I'm going to try to show here, we think that usually when you see a child with pyelonephritis, and then you have a DMSA or a classic pyelonephritis case, we always assume that this child will have vesicoureteral reflux. And actually, not 2/3 of them will have VUR, but as shown by Rushton again, only 35%, 37% were found to have vesicoureteral reflux. So there are many other reasons why children could develop an infection that is located in the kidney in terms of pyelonephritis, but not a VUR being the most common one. So this is what we know. VUR is seen in up to 2% of all newborns. Like I said, 25 to 40% are seen have VUR after the first investigation post UTI. And then kidneys, we have higher grades of VUR, are more likely to develop pyelonephrotic or changes on the MSA than those who have grade 1 or 2. So again, that's what I mentioned. I just would like to highlight this, that even though a VUR may be present in a child with pyelonephritis, the majority of children with pyelo do not have VUR. So when we talk about pyelonephritis and VUR, I think it's important to talk about this top-down approach for urinary tract infection. So this is an alternate approach to imaging of a child with febrile urinary tract infection. So usually what's recommended by those who like to follow this approach is that you're going to order a DMSA after the first febrile UTI, and then doing VCUG only in those who have abnormal renal scans. So the reason here is to try to avoid doing unnecessary VCUGs in those children, and with the premise that those who have, again, shown photopienic defects or inflammation that kidney, they will be more likely to have scarring and more likely to have high-grade VUR, then of course be detected by a VCUG. So the downside of this approach is that it may miss 15 to 30% of children with dilating VUR, and then this is more, it's highly proposed by the Europeans, but then has been disseminated well in South America. And according to the NICE guidelines, the DMSA should be performed 4 to 6 months after an atypical, that we can define a urinary tract infection, or recurrent UTI in children younger than 3 years of age. The AAP guidelines, as you know, does not recommend routine DMSA after urinary or febrile urinary tract infection. So talking about the AAP guidelines from 2011, what do they recommend? First of all, ultrasound in all children under 2 years with a febrile UTI, no VCUG if the ultrasound is normal. So if you're going to do a VCUG only after the second febrile urinary tract infection. So once they released this, the section of urology of the AAP, I was a bit concerned that maybe a lot of those cases, as I mentioned, the UTIs are responsible for a lot of the workup for fever in the community. So they are concerned that a lot of children will be underdiagnosed. So they released a statement saying that the VCUG should remain as an option, an accepted option up to now. This was 2012. And why? Because they're concerned about those with high grade of VUR, that they could benefit from early detection and treatment to prevent kidney infection, damage, and loss of function. So what I would like to talk here is just one slide to try to link these conditions about the non-surgical management of vesicoureteral reflux. So as I mentioned to you guys, in terms of the AAP and the NICE guidelines, do not recommend prophylaxis after the first febrile urinary tract infection. Some will not even investigate because these patients do not have, for instance, vesicoureteral reflux or other conditions that would need to be prevented by antibiotics. So the benefit of antibiotics, as I mentioned and has been highlighted by the River in the Swedish trial, is in girls with dilated vesicoureteral reflux. So antibiotic prophylaxis should not be indicated or given to boys who are circumcised, those who do not have bowel bladder dysfunction. So if a girl doesn't have BBD and low-grade VUR, may not need antibiotics. Those with a normal ultrasound or DMSA, if they don't have anatomical abnormalities and they do not have dilating VUR. So the River trial showed that the CAP was able to reduce the risk of recurrent urinary tract infections, especially I have a specific benefit in those. The reduction was greater in those who had BBD and those who had a history of high grades of VUR and a history of febrile UTI. So in terms of this statement, which of the following is false? Great, so 60% got it right. We're going to talk about this now. It is important to talk about those guidelines because, again, we live and die by them. We're supposed to be practicing evidence-based medicine, so we need to know and understand well what the guidelines say. And in terms of the answer, as I mentioned before, the AAP does not recommend routine DMSA for evaluation after first febrile UTI, but in terms of the UK, like the British guidelines, they recommend for children with atypical UTI. So what is atypical UTI? Is a patient that is either septic or ill, toxic, that the antibiotics or is not responding to treatment for 48 hours, has elevated creatinine, non-E. coli UTI, or those who have recurrent infections. So in terms of surgical management, I just put this slide because, again, this has been less common, but I still perform a lot of surgery for vesicoureteral reflux, especially in the US with robotic approach. So at least in my institution, and then from textbook indications would be breakthrough UTI that occurred despite antibiotic prophylaxis. Patients who are non-compliant in Canada, sometimes this is a reality that they're in the northern territories, they don't have access to like a good family doctor or a good tertiary care hospital. So then it's better to correct them to avoid them having multiple bouts of UTIs and pyelonephritis. Those with severe reflux 5 or 4, but we have parenchyma compromise. So this is a relative indication, and patients who have new scars, if you're able to prove, then I think for sure this needs to be corrected. So I would like now to make a summary of those recommendations in terms of imaging for urinary tract infection. And I recommend those who want to have a more detailed review of this topic to go to the article that was nicely written by Dr. Kopp in the North American clinics in 2015, if I'm not mistaken. So this summary, it means that an ultrasound should be used because it's non-invasive, inexpensive, and safe. So it's usually and commonly used for the evaluation of the urinary tract. So when you check for hydronephrosis, duplication anomalies, etc., but it's unreliable for VUR. If done by experienced hands and where they have a good experience, it can identify pyelonephritis. So for young children with the first UTI, the ultrasound is unlikely to alter management, therefore not universally recommended. So a nice paper from the University of California, San Francisco, Dr. Kopp and then collaborators, they just published in 2020, showed a very nice paper, decision model, which showed that if you do an ultrasound, it's not cost effective. Look at this. We had to have 91 patients screened to prevent 1 recurrent urinary tract infection. The same group showed that after the first febrile UTI, 20% of children that had an ultrasound versus 12% that didn't have after the first UTI would receive unnecessary VCUG. So because the ultrasound maybe would show like, I'm imagine like a little bit of a hydro or something, or maybe doctors would prone to this investigation. But I think the bottom line is that if you have a first UTI, you don't need to order a renal ultrasound. So in terms of the NICE guidelines, they do recommend an ultrasound after first febrile UTI in young children less than 6 months, or as I mentioned before, in those that are older than 6 months, but they have those more severe UTIs like sepsis, like don't respond to antibiotic for 48 hours or recurrent urinary tract infections. AAP guidelines, we know well, it's for children between 2 and 24 months, and then ultrasound is done after the first febrile UTI. So in terms of VCUG, what we know about VCUG, again, radiation exposure is more expensive and it's invasive. But it's the most commonly, at least for now, we know that now there's new modalities that are coming up with ultrasound for VUR, some particles that can do a different type of VCUG, but so far the gold standard is the VCUG to evaluate for vesicoureteral reflux. According to the British guidelines, the NICE guidelines, VCUG is indicated for children under 6 months with a typical recurrent UTI, or those who are between 6 and 3 years, have a typical recurrent UTI, abnormal ultrasound, or poor urinary flow and VUR, family history for vesicoureteral reflux. The AP guidelines, which is I think it's much straightforward, not because we're in North America, we follow this one, but again, the VCUG is recommended for those between 2 and 24 months after the second febrile UTI, not the first, but the second. Or if they have, it's going to be done after the first in patients who have abnormal ultrasound, like hydronephrosis, duplication anomalies, bladder abnormalities, or if they have high-grade vesicoureteral reflux, again. So in terms of the DMSA summary, again, it's time-intensive. In our hospital, is the #1 cause of complaints because with the IV in young babies, so it's less radiation, but it's invasive, expensive, and time-intensive. So it gives you information about renal inflammation and renal scarring. What is important here is that children with acute DMSA change are at higher risk for grade 3 to 5 vesicoureteral reflux on VCUG. So that's the rationale that the top-down approach used to order the DMSA first and then select patients for VCUG. Both NICE and AP guidelines do not routine order DMSA for evaluation of the first febrile urinary tract infection. So that's why that answer in that question was wrong. In terms of the DMSA for evaluation of clinically significant renal scarring after a UTI is still controversial. NICE guidelines recommend doing the DMSA 4 to 6 months after, again, for same indications, a typical infection or recurrent infection under 3 years or recurrent infection above 3 years of age. AP guidelines do not recommend DMSA. So we're almost at the end. We're going to talk about the treatment of UTI. So if the patient is the first infection, so what is recommended treatment for 7 to 14 days. And then this is sometimes protocol dependent from institutions, but you have to adjust based on the sensitivities. So one important thing is that you should not use nitrofurantoin for pyelonephritis. And the main reason is because it's an excellent antibiotic for prophylaxis, because it has minimal effect on the flora, but it has poor tissue penetration. So therefore, you should use antibiotics that are stronger, that can penetrate the tissue and treat the pyelonephritis, because the patient's sick and you want, really cure or response, quickly. In terms of patients who are going to go for radiologic evaluation, so you should consider giving a prophylactic dose. We're actually running a trial on that to see if it's necessary or not. And this has to be discussed with the parents and accepted by them. So the prophylaxis in our centers, or if the patient has VUR or BBD that needs to be on prophylaxis, we recommend just not Septra, but we go with just the trimethoprim component, 2 milligrams per kilogram, or nitrofurantoin, which limits the use in older kids because of the bad taste, but it actually is an excellent medication for prophylaxis. In terms of, again, treatment, it's important to know that the urine becomes sterile after 24 hours of successful treatment. So if you have an inpatient after 2-3 days and they need to have a VCUG or any invasive test, the urine should be considered sterile, even if I can scope this patient, and we have done it and without any problems. What is important here is that about early treatment will limit renal scarring. So according to ONL in 2012, so the scar formation increased from 22 to 60% when the start of antibiotic was pushed or postponed from 2 to 3 days. So if the patient stays at home, or if the patient presents to the ER and they're told to come back 48 hours later, this may be significant, because then renal scarring may develop in up to 2/3 of those patients. Again, according to O, scar formation went from 11% to almost 80% when we postponed this treatment for almost 7 days. So the key message is early treatment will prevent and limit the renal scarring. And finally, my last slide, because again, it's another lecture by itself, is that we need to have in mind that exposure to antibiotics will increase the likelihood of bacterial resistance. And this is now a hot topic and very important, and that's why we need to tailor the treatment to specific high-risk groups. So in conclusion, I would like to say that UTIs are very common in childhood, represent 7% of the workup for fever. Any child that presents at any office with an investigation for fever, 1 in 10 will have a urinary tract infection. The accurate diagnosis and early treatment are very important, because with them we can limit development of renal scarrings. We can prevent major consequences if they don't have dysplasia of hypertension and even end-stage renal disease. We should be able to identify the risk factors, and the main ones would be girls or even boys, but with bowel bladder dysfunction, the presence of the foreskin, it's a known risk factors, in patients with vesicoureteral reflux or other urological anatomical abnormalities. And at the end, you have to weigh benefits of treating against the risk of increasing bacterial resistance and tailor, like even treating of and management of vesicoureteral reflux for those with high risk groups. And again, I think I've seen a lecture that will come in the following weeks about VUR, and I'm sure that they will dive in depth about how to manage and treat properly vesicoureteral reflux in those high-risk groups. So I would like to thank you very much, and then I'm open for questions.
Thanks, Dr. Braga, for the lecture. We do have some questions here online. One is, Dr. Braga, do you order a VCUG in all patients after their first febrile UTI?
If I order VCUG as a first febrile UTI, so again, I do not order a VCUG. I would wait. I think the important thing would be to follow. I'm more in line. I try to follow evidence-based guidelines, so I like to follow the AAP guidelines. So the caveat there is that it goes from 2 to 24 months. So in order to order the VCUG after a first UTI, then the ultrasound has to show some abnormalities like hydroureter, hydronephrosis, or bladder trabeculation or megacystis, or any type of bladder abnormality or urethral abnormality that would indicate in favor that the void and cystic ureterogram.
Perfect. We have a question from Mexico, actually. Do you treat patients with non-febrile UTIs?
If I treat them, so again, as we've seen, I think we need to, it's a generic question. I think it's important to find out, again, the age of the child, the gender, if this child has, again, bowel bladder dysfunction. I'm sorry if I'm repeating those risk factors, but that's very important because you have to tailor the treatment. So I think to answer yes or no would not be accurate, because I would say that most likely than not, the answer would be no. But in some cases, yeah, I have had treated patients, but they have some risk factors that we had to treat them, or forces us to treat them.
I have a question here as well about yeast in the urine. Can you talk a little bit about yeast urinary tract infections? Like, when would you like to treat them, and can they be ignored? And are there certain populations where they must be treated?
Thank you. That's an important question. I think, so as we've seen here, and then when we do a urinary tract, when you do a urinalysis or a urine culture, usually, unless you request that for them to look for fungal or yeast infection, sometimes they may not be looking to this. I'm assuming that's what the question is leading to. I hope they are not talking about just colonization in vulvovaginitis or something like that, that it's in there and then you can have yeast in that flora. But again, most patients that I have had to treat for yeast infection are some patients with very severe urological abnormalities that have been in the hospital, immunosuppressed, had either the presence of nephrostomy tubes for a long period of time, or catheterizations in the urinary tract that prone them to develop those yeast infections. And then some patients can go even further and develop like fungal balls that are like, challenged to be treated. And then usually those patients are sick, or they may need more intensive type of treatment with amphotericin for a long period of time. So usually these are patients that we are contacting ID to help us and manage them. But in terms of regular urinary tract infections, no, I think most of the time, again, the most common etiology is E. coli, which would be present in 80 to 85% of the urinary tract infections in the community.
Okay. Thanks, Dr. Braga. I have a question here about how long you would continue prophylactic antibiotics for these patients.
So again, difficult question to answer, because I think I would like to know for each patient. So I'm going to answer in some scenarios. So I think it depends. The answer would be it depends. So if you have patients with vesicoureteral reflux, I think again we would go back to the guidelines that we have published that from the American Urological Association, and then most of the time. I just mentioned to you guys that I like to follow the guidelines, but this one I have been challenging the guidelines. So the guideline says that patients for VUR, we should keep them on antibiotic prophylaxis, especially those with dilating VUR, with BBD and girls, until they are toilet trained. In our service, we have started a prospective study many years ago, like probably around 6 to 8 years ago, that we decided to stop antibiotic prophylaxis in patients with VUR at between 12 and 18 months. And then we have actually compared that group with a group that had followed the same course of stopping the antibiotics at the age of toilet train. And the rate of UTI after what we call cap discontinuation was the same, around 8 to 9%. So 1 in 10 develop UTI. And those who develop UTI after stopping the antibiotic were girls with dilated VUR and with BBD. So these are the risk group that are probably, according to Dr. Tony Curry's paper about risk stratification for VUR, I think these are patients that are probably maybe deserve to be even intervention and managed earlier, either with antibiotics or even with surgical correction.
Perfect. Thanks, Dr. Braga. And then we have a few questions about circumcision and your recommendations for circumcision. For example, in patients with PUD, would you recommend a circumcision? Yes.
So all our patients, and has been a couple of papers recommending that would reduce the risk of urinary tract infection. So again, in Canada, we recommend, do all patients with posterior urethral valves in Canada get a circumcision? The answer is no, because some families will refuse that, but we advise and mention. It's all about having an honest discussion with the family and weigh the risks and benefits of the procedure. But again, if the patient has been, the valves have been ablated and they are on antibiotic prophylaxis and this is managed. So again, this patient, the last one that we had that was not circumcised and has been doing well so far, but again, not our recommendation. So most patients should be circumcised with valves. In terms of doing circumcision for like a male healthy infant or newborn, the answer will be no. And the reason in Canada, healthcare, universal access, so the system wouldn't be able to, I think, support that as in Canada. But again, as shown, this has not been proven to normal healthy infants to reduce the risk of urinary tract infection. The number needed to treat will be 111. So for those who have grade 4 and 5 VUR, those with recurrent UTIs or other anatomic urological problems, yes, it makes sense. And as we've seen, the number needed to treat will vary between 4 and 10 or 11.
Perfect. I think maybe we'll have time for one more question. It was actually the first question. Why is PUD associated with postnatal UTIs? Is it a question of stasis or is it something else?
So it's a good question. I think posterior urethral valves, as we all know, it's a spectrum. You can have cases that are very, very mild. They present as teenagers or with lower urinary tract symptoms that someone is treating them for voiding dysfunction. they can present as like, because they didn't have proper prenatal care, like Dr. Kopp showed yesterday, those classic findings of megacystis, bilateral hydronephrosis, and oligohydramnios. This would favor a patient to be born with PUV, but sometimes they are missed. And then because of the outlet obstruction, there is bilateral reflux, it stays in the ureters, high post-void residual. So all this are predisposed to infections. On top of that, if the baby is not circumcised, then I think the risk will be even higher. So this will be the main reasons for UTIs in those babies.
Perfect. Well, thank you so much. I think we're getting close to 8. There's a lot more questions on here, and I think we'll make every attempt to answer them. And I think these questions will be published online. Thank you. Yeah.
No, thank you very much. And I apologize in the beginning. My phone went off here, and then this got me distracted. But I think at the end, hope everybody was able to get a good review on UTIs, pyelonephritis, those nice, and then AAP guidelines. And I'm happy to answer any questions by email, or if you guys have, I'll log into this great initiative. Thank you very much.
Thank you again. Stay safe from Canada.